Hello, it's our great pleasure to welcome you to this online advice clinic hosted by Roydsworthy King. My name is Paul Rumley. I'm a partner within the Clinical Negligence Department at Roydsworthy King, and I specialise in Erb's palsy claims. I'm joined by my colleague Lucy Norton, an associate within the department, who also specialises in Erb's palsy claims. The aim of this clinic is to allow people with Erb's palsy and their families to ask any questions they would like about the practical and legal aspects of having Erb's palsy. We are very grateful to be joined in this clinic by Shana, who has a daughter with Erb's palsy who is still undergoing treatment. Shana, hello, and thank you very much for joining us as part of this clinic. We're also very lucky to be joined by two eminent experts in the field of Erb's palsy who will try to answer everyone's medical questions around Erb's. First of all, we have Mr. Tom Quick, a consultant peripheral nerve surgeon. In other words, an expert surgeon in dealing with Erb's palsy injuries. He is heavily involved in research into peripheral nerve injury repair and is widely published as an expert in this field. Tom, thank you so much for joining us. We're also extremely grateful to be joined by Associate Professor Demetrios Siasikos, a consultant obstetrician and gynaecologist. Demetrios has been extensively involved in developing guidelines and training teams on the management of problems at birth, including shoulder dystocia, which can result in Erb's palsy, and so how to reduce Erb's palsy injuries. Demetrios, thank you so much for joining us. Finally, and by no means least, we thank all of the people who are joining us online for this clinic. Please do feel free to send us your questions about Erb's palsy, which the team at Roydsworthy King will try to answer. Without further ado, let's go to Lucy with the first question.
We do, and this one is for you, Demetrios. What options should I have been given about how to have my baby, given that the midwife told me that he was going to be big?
I think every woman deserves to have a meaningful discussion with regards to mode of birth, whether a vaginal birth or a cesarean section is indicated or not, depending on a number of factors, including the weight of the predicted weight of the baby, but also other factors like medical history, history of diabetes, what happened in any previous pregnancies, and importantly, the family's preferences.
And in practice, does this happen all the time?
It should happen, and as many people know, there was a ruling only a few years ago that said that doctors should improve in having this discussion with women with regards to mode of birth, vaginal birth versus cesarean section. We also know that unfortunately that does not seem to be happening as well as it could, even though it has been a few years since that ruling. But a number of us are involved in a number of initiatives trying to improve the situation.
That's good, thank you.
So we've got another question. I think probably, Lucy, this is one for you to begin with. Question is, I still don't feel I understand what happened to my little girl during her birth. I had a lot of gas and air and it was a bit hazy and no one really explained how she was injured. Should I make a complaint or is there any other way?
I think first of all, the options that you have is to have a debrief with the midwives at the hospital. So if you don't feel that there was time to do it immediately after you had your baby, most hospitals are happy to talk you through what actually happened. So that's one way forward. If that is not appropriate for you or some time has passed, you can use PALS, which is the Patient Advice and Liaison Service, and they are a useful go-between yourself and the hospital to put forward your concerns or complaints to actually get some answers about what's happened. Many people find that useful and they like the intermediary aspect as it feels slightly less confrontational. If you have already been down that route and you're still not happy, then you can send a formal complaint, and these should be addressed to the chief executive of the hospital, at the trust where your baby was born, or the trust that is responsible for the midwifery care, for example, if you had a home birth. They generally say the guidelines that are laid out is that complaints should be made within 12 months of the date of birth, because after that time, obviously staff move on, memories, fade, and it's a lot easier to investigate something sooner rather than later. If you do a formal letter of complaint, then they should respond within a maximum of 6 months. Some obviously are quicker than that, others take a more detailed time to investigate. The next step on the chain, if that hasn't resolved your issues, is to bring a complaint to the Health Ombudsman or the Care Quality Commission. That's much more detailed and takes a lot more time. Alternatively, there is also investigating a potential claim. So as lawyers, quite often people come to us because they haven't had the answers that they were looking for through the complaints process, and sometimes we can provide them with those answers by doing a formal investigation and getting experts on board to say whether or not that treatment they had was appropriate. And that's when we would get people like Demetrius to have a look at things and say, well, actually, what's happened to you is reasonable, or actually what happened to you wasn't reasonable. And we can then help people further from there.
Demetrius, what's your view of what should happen after a traumatic birth?
I think explaining what happened as soon, first of all, during a traumatic experience, either before, during, or after birth, it is really important that there is good communication with parents and their families. Because we do know from some of our research that actually trying to explain things a long time after they happen doesn't seem to work. What is really important to explain things, even if briefly, whilst they are happening, and then as soon as possible afterwards to give a more detailed explanation. So the briefing that happens 3 or 4 months after the event doesn't really work. So communication is really, really important, and it doesn't have to be extensive, you see. Often 1 or 2 sentences will make a difference to the experience, just explaining what is happening and what is likely to happen. So for example, with shoulder dystocia, which is when the baby's shoulder gets stuck, members of staff have to do 1 or 2 things really, really quickly. And some of those things involve moving the woman into unusual positions, or even pressing really hard on lower down, just above her pelvis. And that can be painful. So explaining with 1 sentence that we have to do things quickly, some of those, we don't have time to explain them. Some of those things may be slightly uncomfortable, and I will explain everything afterwards. It took me 30 seconds to say it. It makes a massive difference to the experience of a family who's having a shoulder dystocia, for example. And then explaining, this is what we did and why.
Well, and of course, that's in keeping with the duty of candour as well, isn't it? You know, to be open and honest with patients as soon as you can. So that makes sense. Shana, were you offered a debrief after the birth of your daughter?
I wasn't offered it, but later on, after she was born, like a few months down the line, discovered that a debrief was a thing and that I could have had it. But had I known after she was born that, like soon after she was born, that you know a debrief was possible, then yeah, I definitely would have taken it up. But no, I didn't. I wasn't offered it.
Were you given any opportunity to ask any questions afterwards?
No, not really. They didn't really say anything to me whilst Lila was being born. Yeah, they didn't really communicate well, like Demetrius said that they should. After she was born, you know, everyone pretty much left the room pretty quickly. No one really explained anything.
So did you feel you understood what had happened and why?
Not all. I didn't think anything went wrong. Obviously, when she got stuck, and then when she was finally delivered, and then they took her away, and you brought her back. You know, when all of that stuff was aside, and I had her in my arms, I thought that she was okay. And the following day when we left the hospital, I still left thinking that everything was okay, that my baby was okay, and I was just pretty relieved that it was over and that I could just take her and enjoy her. But yeah, I wasn't told anything was wrong or anything could have went wrong or something may have went wrong. So no, I wasn't really told anything.
Okay. Lucy, I think we've got another question.
Yes, this time it's for you, Tom. So it's from someone whose child has been diagnosed with a nerve palsy injury. It says, will my baby need surgery? And if so, when? Is there an optimum time?
So I think the most important thing, first of all, is to integrate the care, make sure that you're engaged with a group and a multidisciplinary group so that all the other options can be laid out, the information can be given. So that answer is very difficult to explain in a simple manner, in that there are early surgeries which are on the nerves, and the assessment for that really has to be done as early as possible, certainly by 2 or absolutely by 3 months old. You need to be making a decision whether the natural history of recovery is going to be good and whether that can be improved upon with any primary nerve surgery. And that's surgery upon the nerves in the neck which were damaged. There are lots of other subsequent surgeries that are possible to improve certain problems to do with the shoulder, the forearm, the elbow, the hand, and all of those will again evolve over time. But I presume the question probably relates to that early stage, and
Yes.
the most important thing is to get a team to get an assessment from the physios, the OTs, and the surgeon, and to work towards an understanding of exactly what is likely to happen if nothing is done, what the risks of that surgery are, and what the potential benefits of that surgery are, and then to discuss whether that works for you and what the advantages are likely to be for your child.
And how does that work? So it sounds obviously they should be seen sooner rather than later,
Yeah.
but who directs that? Does that come from the paediatrician or directly from the obstetric ward?
Yeah, so we have no national referral framework in place, and that's something that we're trying very hard to put in place so that there should be a more structured manner for this. But in simple terms, the referral can be made to any of the major units, and there's a number across the country, and that can be from the neonatologist, the paediatrician. It can be from the obstetric unit. It can be from physiotherapists, and sometimes orthopedic surgeons are involved locally as well and called in to make an assessment and to assess whether the referral onwards is needed. So really, again, it has to be somebody within that healthcare team, or indeed sometimes occasionally a GP. Parents may well say, the team that have been involved in my local hospital are not giving me what I require, and the GP writes in and says, we'd appreciate your opinion on this young child. So the referral can come in from anywhere.
So it's not necessarily about early surgery, it's about early assessment.
Yeah, and I think the most important thing, I think it's exactly what Demetrius, my colleague, has just mentioned, is that information is absolutely key. It's meeting people who can give you the answers, who understand the condition, and can weigh up the options for you, be the advocate in explaining what the possible options are, and working with you to work out what's best for your child, for your family. And that doesn't necessarily need to have to be surgery. In many cases, surgery is likely to give benefit, but that may not be right for each individual.
Thank you. Very helpful.
Well, Tom, the next question is also for you, and that's, what will surgery involve, and is it likely to mean more than one operation?
Okay, I'll deal with the second part of that first, if I may. I, some 8 or 9 years ago now, undertook a study of all the patients that have been through my unit in London. And we recognised that of all comers referred to a specialist unit, on average in their whole treatment, there was 2 1/3 times that they needed an operation. So times that they had to go and have an operation to give them some benefit. So on average, 2 and a bit. So some have 2, some have 3, some may have 1, some may have none, and some may have more. So there's going to be a range. But if you have a mindset that probably 2 and a bit is about average. As I say, it's sensible to split the operations up into groups. The primary early surgery, the surgery upon the nerves to improve the outcome for the nerve injury itself. And that is best done at around 3 months, and certainly I would say by 6 months. Sometimes that has to be later, but ideally between 3 and 6 months. Very occasionally, in a complete palsy, where the hand is involved as well as the elbow and shoulder, then we operate earlier at 2 months. Then the subsequent surgeries, as I've mentioned, for the shoulder, for the elbow, for the forearm, for the hand, they can happen at any stage, and often there are different types of operations we do at different times, depending on what problems come. And the basic principle of that is that the nerve injury creates imbalance. It damages some nerves more than other nerves, and as the arm grows, this imbalance in nerve strength and nerve control and nerve feedback leads to problems that can develop with growth. So until the child is fully grown, and that's skeletal maturity, which is in young girls between 12 and 14 and young boys 14 to 16, growth is likely to continue to be unbalanced, and thus problems can occur, normally most around the shoulder, but also at the elbow and the forearm and the hand. So over that period of growth, lots of different types of surgery may be necessary. And on average, as I say, if you think over the whole lifetime of growth, around 2 different types of operations.
Jana, what was your experience of treatment for your daughter?
The paediatrician, we didn't actually see a paediatrician until she had already been seen by Leeds. So the day she was seen at Leeds Hospital first, where she had her assessment, the following day is when she first saw a paediatrician, and she was, I think she was 3 months old. She was just over 3 months. So yeah, we got referred to Leeds by a woman that works within the palsy charity. So she went to Leeds with us, and then we got the assessment there, and Lila scored under what she should have. So that meant that she would have benefited from having nerve graft surgery. And then we went back a month after that to have a pre-op appointment, and then at 5 months she had nerve graft surgery. So yeah, the hospital didn't actually refer me. The hospital didn't even see Lila until Leeds had already said, okay, here's her assessment, here's the grade that she got, she would benefit from surgery. But overall,
sounds like
surgery is definitely benefited her.
It sounds like quite a difficult pathway, helped by the Erbs Palsy group.
Yeah, definitely. I definitely didn't expect for it to take that long for me to get help and understanding about what had actually happened to her and how much help she might need. Obviously, considering I left the hospital thinking that she was okay and that she would be okay, and then to only a few months down the line being told that my baby would benefit from having surgery, and that actually the issue that she has is going to last a lifetime. Yeah.
No, difficult. Lucia,
Yeah.
another questions come in?
Back to you again, Tom, I'm afraid. How long should my child have physiotherapy for? I'm concerned he's been discharged too early.
So physiotherapy is absolutely essential, and essential until skeletal maturity, and probably onwards then into adult life, particularly as you're more likely to run into problems with the shoulder and the arm, and probably the back in adult life as well. So the basic principle that an input of physiotherapy is going to improve quality of life is absolute. I mean, I think everybody appreciates that. The problem is exactly how it should be provided and by whom. Certainly within the early period, the neonatal period, and the period of childhood, it's really important that that's embedded within a team, so that you have expert physiotherapy input, but you also then have local therapy as well. You can't always be going to Leeds, to Birmingham, or to London for that physiotherapy. But again, you need to recognise that physiotherapy is something that is done within the family, and that the mum, the dad, and the child themselves, when they get to adolescence, is engaged to do their own physiotherapy. In the same way that if you have a fitness coach, they don't do the fitness work for you, they'll advise and they'll support, but you have to integrate the importance of those exercises and stretches and strengthening and coordination into a daily routine. And that's difficult, certainly at different time periods in growth. Certainly around 2 years old, we get that terrible twos. It's very hard to engage kids in physiotherapy. But the principles then are you try and make it into play and integrate it in that way. And then again, in adolescence, it's often hard. Life becomes a lot more busy, and there's a lot of other demands on adolescents' time. And so again, identifying the benefit that the patients gain from that and trying to encourage them to continue. So it is absolutely important. It should continue. It should be supported in a specialist centre and in regional therapy as well, but it needs to happen within the home.
I have a client where he is fortunately very sporty. His parents are very supportive. You know, they have helped him and made him do different activities to get all the different exercises in. But he was discharged probably around the age of 8 from the actual physiotherapy clinic. And I felt that they should be going back to say, actually, we need a little bit more help, because although we're doing it really well ourselves, they're not specialists. So I would assume they should be looking to get re-referred.
Absolutely. And I think it is that idea of the way the NHS is working now is the way physiotherapy appears to be provided. It's individual packets of care. And I'm constantly writing letters saying you need to accept this is a lifelong condition, but it definitely has to be locally supported until adolescence, until skeletal maturity. Now that doesn't seem to be changing anybody's practice, and people are constantly discharged and then get re-referred and start a new episode of care. I think it's just one of the problems we're having at the minute with funding within regional health. But absolutely, I think it is an important thing to get re-referred, to maintain that support, but not to say just because you're not actively under a local therapist that you can't access specialist care and that you can't access continued home-based physiotherapy on the advice that you've been given before. So keep that going. Again, try and reach out to the specialist centre and through your GP back to the therapists and get re-referred and maintain those links and that support.
Jana, what's your experience been in physiotherapy?
We obviously do it more than anyone else does with Lila. At first, when we first discovered what was wrong with her, that she had Earl's palsy, the physiotherapist came around quite often, every week, every 2 weeks, and then it went to like every now I think it's like every 3 or 4 months, just because now she's had surgery, they want to need it some time to see if her arm has improved, just because obviously now she's got new nerves from her legs in her neck. But yeah, doing it myself, it can be hard, like Tom said. Definitely, therapy too is very difficult to do physio with Lila, but I do try and make it into a fun thing, into a game. Sometimes I'll put on a song and I don't know, I'll tell her to clap her hands really high, or tell her that you love her this much, and just get her to do any kind of movement that she can where her exercises are fitting in with it. It is difficult, definitely. Yeah, it is difficult, but it is a need. It is really, really important. I've spoken to other parents before that say things like, yeah, but what's the point in doing it? Because you're saying you do it this much every single day, and I'm not seeing any benefit from my child, after just feel like I'm wasting time. It's a slow process. You're not going to do physiotherapy for a few weeks or a month or so and expect to see a new movement or new feeling, anything like that. It doesn't work that way. It really does take a lot of time. But yeah, it can definitely be hard, but it's worth it. Like in January, Lila had an appointment with the Stark checkup, and they thought what I thought that her arm was a bit stiff and that she'd probably benefit from shoulder release a few months down the line. But then when she went back 6 months later, she got seen, well actually it was a bit later than that, she got seen in November last year. And they said that her arm wasn't, didn't seem stiff anymore, that the physio exercise that we carried on doing, mainly this one, which is very important, that the physio really benefited her arm and that it wasn't looking like she needed just a shoulder release anymore, which I was obviously really happy to hear. So yeah, it's really important to do physiotherapy, really, really important. Even if you can't see change soon after, you just have to keep doing it. And at least, even if not much change does happen, even if you have been doing it well, at least you can say you've tried. You have to help your child work their arm. You have to do it for them when they can't do it. It's really important.
Lucy, I think we've got another question.
Yes, this one's for you, Demetrius. If I'd been offered a caesarean section when they knew it was a big baby, then I would have taken it, but no one offered it to me. Why not?
And I think we go back to the problem we discussed earlier, is that we are meant to discuss mode of birth. And sometimes one option would be recommended over another, but we always have to discuss both options with their advantages and disadvantages, with maternal preferences taken into account. So not even discussing a cesarean section, or even worse, for someone to actually inquire about the cesarean section only to be told off and say, oh, no, that's not an option for you, there's no point in discussing it, is not modern care and should not really take place. I think I could not be any clearer that the cesarean section is an option that needs to be discussed, even if it's not the recommended option, particularly when women inquire about it.
Thank you.
Next question to you, Lucy, I think, but Demetrius, you might also have a view on about it. What about injuries to mum as well as to the baby?
Quite often with cases of shoulder dystocia and the ensuing delivery, mums can sometimes sustain tears, 3rd or 4th degree tears, and this quite often leads to incontinence, which is obviously what everyone would like to avoid. The difficulty with this is sometimes mums take a little bit of a backward step, shall we say. They're very concerned about their children and what's happening with them, and sometimes, very sadly, they just put it down to it's one of those things, that's what happens in childbirth, which really is not the case. Sometimes things can't be avoided, sometimes things can be helped, episiotomies can be offered, but if there is a problem such that these kind of tears can be avoided, I think with appropriate management, which Demetrius may talk about, that can be avoided, but also should be then treated as well. I think there's so much going on that mums don't actually always look after themselves in the first instance, and then when the focus is on the child, when the child has an injury, things don't always get dealt with. I think that's just my perception from the cases we see of people coming to us. Quite often we speak to parents and the focus is all on the child and the injury they have. We then inquire, how about you, mum? How did you get on? And you're like, oh, well, I had to go back down for surgery, but I've been having problems since. I'm a bit concerned about having another baby because it might all happen again. And then we then look at psychological injuries, which is also there. These types of births are traumatic, and as Demetrius said earlier, little things can make a massive difference to that person. If you're frightened, if you're not told what's going on, it makes everything that much more difficult. And sadly, we see cases where mums do get sort of quite bad depression or even post-traumatic stress disorder and anxiety, and these things also need to be treated. So we can help with that in terms of the claims we bring, but importantly, mums shouldn't forget about themselves. They should see their gynaecologist, they should see their GP. They should ask about counselling. The debrief that we talked about earlier can be part of that. Having some knowledge. Knowledge is power. It helps you process things for yourself as well as for what happened to your child. And so, mums, please don't forget yourselves.
Dimitri, is there anything you want to add to that?
Yes. Having a vaginal tear and generally having complications from a vaginal birth on the pelvic floor, it's something that has to be balanced obviously with the risks of a major operation, and the cesarean section is a major operation and usually it goes really well. But for a small number of women, there are complications and the complications can be significant. That said, the problem with mothers, as Lucy explained, is that generally having an impact on the mother, even if that impact was significant, was something that historically was neglected and thought to be part of normal birth. And that has caused a significant amount of physical and psychological injury over the last few centuries and decades. So it is now at last being recognized that actually paying attention to the impact on mothers is really, really, really important in a number of ways. Because, for example, as you mentioned, when the baby's shoulder gets stuck, then there is a high risk that the mother will get a bad injury to her perineum and her pelvic floor. So optimal care and actually reasonable care starts with recognition that it has happened in the first place, and that's often where some of our failings are. We fail to recognize that there is a severe tear so as to repair it appropriately. So it has to do with appropriate recognition, diagnosis of a tear, appropriate repair, and then appropriate follow-up. Follow-up that includes things like, for example, antibiotics and avoiding constipation, but also things like pelvic floor exercises that are as regular as possible for the rest of the life of that particular woman. And similar to what we were discussing earlier, that's where we tend to sometimes fail. So we fail to explain what happened if we make the appropriate diagnosis in the first place, and to discuss appropriately with women what should happen afterwards to reduce the impact on their long-term quality of life.
Thank you, Shana. I mean, I appreciate your daughter likewise was your priority, but what helped you with any physical or psychological problems?
Physically, I didn't suffer any tears or anything like that after she was born. Mentally, I suffered. I didn't talk about it for the first few months after she was born, not even to my partner, not to my mum, anyone. I definitely didn't want to go to my GP about it because I thought that if I went to someone like that, then they would think that I can't look after my children or that I'm a bad mom when I can look after them. And I know I'm not a bad mom. I know I'm a good mom. But I did eventually open up about it, and then I did end up going to my doctor about it because I thought, okay, help's there if I need it, and it's important that I get help as well as Lila, because not only has she suffered, yes, physically, but because of everything that's happened to her, I have also suffered too. And it is really hard admitting when there's something wrong with you mentally. Obviously, physically, it can be a lot more obvious, but mentally, no one can see that. No one can see or understand sometimes, what's going on with you in your head. Sometimes you don't understand it yourself. But yeah, I did get help. I'm still getting help now for it. Things get a little bit easier as Lila's gotten older, I think, because I can see a little bit more of, whether she's improving or not, or what she can and can't do, which has helped. But obviously, it's took a long while to get to this stage. She's going to be 3 soon. So when she was a baby and I was learning about, okay, she's got this disability, okay, what does that mean for her future? I did worry about a lot, I did stress about a lot, I got very down. And just lots of other stuff. But yeah, things definitely get easier now. If any mom or dad, because it does obviously affect dads too, ever get, in like in a difficult mental state about what's happened to their child, you can definitely seek help. It's worth doing because as much as your child has been affected physically, it can still have an effect on the parents, definitely.
And I think there's a really important message in there as well, Shana, that actually if you don't help yourself, you can't actually help your child. So that's a really important message, I think.
Yeah.
Another question, probably to Demetrius first of all, but also possibly to you as well, Shana. Question is, I have been invited in to see the midwife to go through the birth, but I don't really know what questions to ask. Demetrius.
Well, that's an interesting one. It depends on the context. So if someone has been invited to see the midwife, I think it is a good opportunity to ask. I don't think there is a rule as to what should and should not be asked. I think it needs to be a discussion that is driven by the concerns of the woman and her family. As far as staff are concerned, if there have been any problems with care identified during labor, as you mentioned earlier, it's a good opportunity to be open and honest as to what happened and how staff dealt with it. So from our point of view, I think it's very clear what definitely has to be covered. I don't see debriefing appointments after any emergency, including shoulder dystocia, as something that should have a fixed agenda, because it goes against the principle of consent and communication that we discussed earlier. The whole point, and that's where we fail, is that any discussion between a senior professional and parents and their families needs to be driven by what is important to the families. So ideally, we should always start those discussions with understanding our perspective and where we're coming from. So what are the parents' concerns? What are our concerns as members of staff? What do we think we could have done better? So that's a useful starting point, and then we take it from there without a fixed agenda.
That's very helpful.
Yeah, no, very helpful. And Shana, I know you weren't actually offered a debrief, but would you have welcomed the opportunity to ask some questions about what happened?
I did eventually get round to getting a debrief. When Lila was 10 months old, we had her debrief, but it was something that I had to push for. And it was hard to get to that stage. It took a while for it to actually happen. But yeah, I definitely asked a bit of everything. Like Demetrius said, I don't think you go in there thinking, okay, I'm going to ask this, and this. You kind of get there, and everything just flows. Yeah, you definitely just ask a little bit of everything. Why did this happen? What does this mean? You definitely, well, I did anyway. I learned a lot of things that happened in Lila's birth that they didn't tell me about. No one that assisted Lila's delivery told me about, that this new person that was at the debrief had told me about, things that I didn't even know. Even if it seemed like something little and important to the staff that were there at the time, it was still something that I feel like I should have known at her actual delivery. Yeah, it definitely helped having a debrief. But yeah, I don't think there's any set things that you should ask. You just kind of go there with a bit of an open mind, because you don't ever know what they're going to say back. Some things you might not agree with. But yeah, it's definitely worth, if anyone ever gets the option, definitely worth going for it, so you gain a better understanding of what happened and what it all means and how to go from there.
Certainly, if
Paul,
clients
allow
ever
me to
ask
say
us... Go on, Demetrius, sorry.
Allow me to say, Paul, and sorry for the interruption, that we do know, so I was saying that there's no fixed agenda, but in terms of what is common, we do know that in terms of parents who experience traumatic events or difficult emergencies, they are the most common questions, is what happened and why, what does it mean for me and my baby, and what happens in the future. What happens in the future to us, including future pregnancies, if that's an important consideration, but also what happens to the hostel and the systems in the hostel if something went wrong. And we know these are usually common questions that tend to come up in such discussions.
Yeah, and all I was going to say was, when we're asked by clients about this, what we say to them is, have an open discussion. It is sometimes helpful, though, just for the families to write down some of the concerns that they've got, not necessarily as questions, but because sometimes when people get into the meetings, they kind of get brain freeze, and it's quite difficult, Yeah, exactly, for them to follow it. So we say to them, write down some things that you really want to know. But you're quite right, Demetrius. They are kind of the overarching things that families do tend to want to know. Lucy, I think another question.
So I had an assumption that an Erb's palsy injury would trigger an investigation, like a serious untoward incident report or similar. But is that always true? Is it classed now as a serious incident to investigate?
And I think it's a straightforward. The answer, yes.
Okay.
It doesn't get any straighter than that. The answer is it's a never. And as you both of you know, I am of the opinion, together with some other experts, that it's a never event. An Erb's palsy as a result of birth is something that is avoidable, and I tend to have a strong opinion on that. It can be avoided with optimal care and with good management, with good reasonable management of shoulder dystocia. And because it is a never event, that's why it should always be investigated to find why it happened, so that it never happens again, were it to happen, but it shouldn't really happen. It's a never event.
And is there a point in time where that is that theory? So obviously we get cases or people come and talk to us about births from quite a long time ago, sort of until more recently. So perhaps from the 2000s onwards. When would you say that it's an investigate? Can't think of my words. Sorry. When would you say that it became something that should be investigated? So obviously, perhaps in the 1990s, nobody would have necessarily put it down as an SUI. When do you think that now should be, or in recent times? I'll get the right question in a minute, and then you can answer it.
Absolutely. First of all, my experience, I started working as an obstetrician in the UK 17, 18 years ago. And for as long as I remember, it was the topic of serious incident investigations. In terms of it becoming a never, but they were still happening. In terms of it becoming a never event because there is training in place, I would say for at least the last 10 to 15 years. So anything that happened after 2005 or thereabouts, I think should be a never event. And if not 2005, then 2010. So 10 to 15 years.
I mean, just to echo what you're saying, Demetrius, I agree. Whether it's a never event, whether it's a serious incident or whatever, I think all of these incidents should be investigated for patient safety learning, because only then do we actually learn what's gone wrong, try to sort that out. So I would say that always an investigation should be carried out. What I would also say, and we say to people who contact us, is don't forget that you do have the right to have access to your children's records and those investigation reports. So do ask the hospitals for those. And when they won't give them to you, be persistent about it. There is another question.
Paul, have you got a question?
Yes, I do. So the question is probably to you, Lucy, but also Tom may have a view on this. Question is, I would be willing to pay for private treatment, as I know there can be waiting lists on the NHS, but I don't know where to start.
So first of all, obviously have your own funding. So if you have the money to go privately for either surgery or physiotherapy, that's entirely up to you if that is appropriate for you and for your child. Insurance, so some people have their own personal insurance or medical insurance through their workplace. I know some parents' children are included on their policies, so that's always something to have a look at as well. And the other thing we can look at is also compensation. So if you've had a case, then compensation is designed to put that person back in the place they would have been but for the injury. In reality, you can't give somebody a new arm, you can't make that injury go away, but you can make it better. You can give them options to make it better. You can give them therapy, you can provide them with care, you can provide them with assistive technology. So it has huge amounts of benefits, and that's what it is for, and that's why we bring the cases for these children.
Tom, what's your view of the role of private treatment in care?
I think, first of all, you mentioned the reason for transferring care into the private sector might be waiting times. I would hope that certainly in my service, and I'm sure in other services, resources are always put to make sure that children can get care at the appropriate time. There may be a wait in any sector to organise the correct team to come around to create the operation that is needed. But I would hope that waiting time should never get in the way of good care. And certainly I'd be very upset if that was ever thought that was something which would drive someone to spending their money or using insurance. The next thing I think is to say that private care isn't necessarily better. There's often a thought that you might get more care or more options privately. And again, I would hope that it would be very clear to everybody that you would have all options available on the NHS. But then moving towards that as a choice, accepting all of those things, you may wish to access private care. The important thing is that you don't get lesser care. So you would not want to go to somebody who's not working with LinkedIn teams to have the ability to refer you for physiotherapy and make sure that all the options are available within that private sector. And it is often difficult to switch between the private sector and the NHS, and that's something that you would need to assess that that's still possible so that you can have access to all of the options. So I would go to somebody who is well recognised. And again, I would take the advice of those who are treating you on the NHS or you've been referred to on the NHS. None of us have any problem at all in accepting private care or recommending other people as a second opinion who may be private or within the NHS. So, of course, the options are available: personal choice, your own money, insurance, or indeed payouts from any legal proceedings. But make sure you're getting the right care, make sure you're going to the right people. Just because somebody is saying that they do things privately, you've got to make sure that it's something that they're expert in, and that you're getting a decent commensurate level of care as you would do on the NHS.
We've kind of covered this a little bit already, Tom, but is my paediatrician the right person to discuss treatment, or should I be looking for more specialist help? And if so, what specialism?
So I would say that probably many paediatricians are aware of this condition, but there is a feeling that historically paediatricians, GPs have seen this as a mild condition, that if the muscle function comes back, that's it, it's finished with. And that really is not the case. And anyone who's had any significant period of an arm that doesn't work can have permanent long-term problems that, if they're not followed up, can get worse to a point of really not being able to be fixed. So I would say get to one of the specialist centres within the UK, or indeed, as we've mentioned, anybody who has a specific expertise. And they are people who work in a number of centres who see these cases regularly. I mean, I will treat 5, 6, 7 children per week with this condition and have thousands under my care. So it's a condition that I'm well aware of. It's the majority of my work. I work just within nerve injury. A paediatrician will have to deal with all sorts of problems, and you can't expect them to be specialist in this particular area. So again, it is talk to the Erbs Palsy Group, a very great resource. They're well aware of who the experts are, and make sure that you speak to somebody who has specific expertise. It's useful, obviously, to get the generalism of the medical care for things like any epilepsy or any other problems, and maintain links with the paediatricians. But to get specific care, you really need to speak to those who have the specific expertise.
And Shana, what's been your experience of treatment for your daughter?
Yeah, so I already explained about physiotherapy. It's really important. It has improved her, the movement and the feeling around, definitely. Surgery, she had that 5 months. They took nerves from both of her legs at the back, put it in her neck. that's definitely helps to improve the movement of 100%. Definitely. She used to have like a weightless tip before where her wrist was just very, very bent in. And that pretty much sorted itself out, like pretty much as soon as she got her bandages off. It wasn't bent in anymore. She could move it around. You know, she started to get the feeling the movement back in her fingers really quickly. And obviously now, you know, almost, well, yeah, it's just a little over 2 years since the surgery. She's improved massively. Definitely, yeah. It's really helped. I'm really thankful that she got the opportunity. And I've spoken to another mother before whose son, he just kind of scraped not needing nerve graft surgery. And we were talking about, you know, the difference in her son's injury and then the severity of Lila's. And she said that it's almost like the worse the injury, the better the care, or the better the opportunities that you get for the arm to get better. So because her son's injury wasn't as bad as Lila's, he didn't, you know, it wasn't seen fit to have the nerve graft surgery. But because Lila's was worse, she did get the opportunity, so she did get the surgery. So yeah, I'm just really thankful that she's had the surgery. It was scary to go through it, obviously, it was really scary. But we didn't really have much to lose. She couldn't really use her arm anyway. All we really could have done, worst case, is not really gained anything else from the surgery. It would have just been a bit of a waste of time, maybe that's it. But thankfully she has gained from it.
So we've got another question, and this is probably to you, Lucy. Shana, you might have a view on this as well, though. And it's, I got a copy of my notes from the hospital so me and my partner could go through them. There are things in there that I'm sure didn't happen and other things that are missing. How can I get these corrected?
Well, I think, first of all, it's not really possible to get notes corrected because they are the notes that are written contemporaneously. But I think through discussion or the debrief, that's when you can understand what should have been in there, and talk about things that maybe happened that aren't in there, or things that you don't understand. And if things are wrong, I think it should be pointed out. I don't actually know, so perhaps this is where Demetrius can come in, or indeed Tom. If patients say that's not what happened, or that's not what I was told, is it possible, or is it just a note made afterwards? How does that work?
Very difficult. If I go first, it's a very difficult situation because I know that particularly in the past, notes used to go missing and documentation wasn't always perfect. Sadly, in my experience, I have seen circumstances where the notes that are particularly important to find seem to be the ones that are always missing. And I don't know why it happens, whether that's just random or not. And there is no easy solution, because even the other problem nowadays is that many hospitals are going digital, which creates some fantastic opportunities to not lose documentation anymore, so that everything is kept forever. The problem with digital notes is that they actually limit what can be documented or not. So what I will say is that the personal experience is valuable. Clearly, there is a different perspective between parents and members of staff, and there are some things that are noticed by parents and some things that are noticed by members of staff, and it's actually useful combining both experiences. Because I know, and so for some of the projects that I have done which are relevant to parents who lose a child, so who have a stillbirth, and we know that often there are some really important aspects of care that are really important for understanding what happened, and they can never be found in any documentation, even if it's not missing, and they can only be found in parents' recollections. So ideally what we need is a combination of all of the above.
Okay.
Shana, what was your experience of the notes in your case? Did you feel it did accurately reflect what happened?
Some things seem accurate, and I agree with. Other things, no, definitely not.
It's definitely
Like,
a problem.
yeah, but like it was said, it can't be changed, which is frustrating because then you think, okay, well, anyone who might look back at that might think, no, actually, this is how it happened. And then a lot of other people said, well, this is what's been noted at that time. But, we understand you and Labour, or, you'd have this, you'd have that. So you probably weren't in the right frame of mind to remember everything. But actually, that's not the case. Obviously, unfortunately, because of how things went, regardless of how long I would have been in labour, or, if I had every drug possible in the world offered to me and took it all, I still remember it really clearly. So yeah, for it to be noted down, a lot of it quite inaccurately to how I remember it, and obviously how my two birthing partners remember it, my partner and my twin sister. They were there too. So for things to still be noted down wrong, I even kind of questioned myself, and then I would question them. Okay, when we were here, how did this go? Lila's delivery, and they would answer it kind of how I recalled it, but then it would be noted down differently. And it's very frustrating. It's very, very annoying. Definitely.
Yeah, and from our perspective as lawyers, it's really important because sometimes these records will prove a case or will provide a defence. So they are really important that they are accurate.
Just going to add, obviously you don't ever really know when it's been documented, whether it's been documented right after a baby's been born, or just before they've been discharged, or whether it's been a few days later and it's just quickly been wrote down, or whether it's been wrote down in detail. Yeah, there was a few things there where you couldn't really make out, like who, like they would note something down, like discussed risks of shoulder dystocia, for example, in my notes, but they didn't state who with. And when there were questions about that, they obviously said, which they were going to say, that they discussed it, with me, but they didn't. So they must have discussed it with themselves. To write down in the notes, discuss shoulder dystocia, that could have been two things: either with myself, or it could have been amongst themselves, but they didn't state that. So again, that's another frustrating thing.
Absolutely. Just so that everybody's aware, if a note is written after the event, it is supposed to be clearly marked as a retrospective note. We do sometimes see that, but it does have to be marked as a retrospective note. Lucy, another question.
Yes, this one's for you, Tom. Are there any other non-surgical forms of treatment for herbs?
Yeah, I think we've spent some time this afternoon going across the concept that any care nowadays really benefits from it being holistic. And so you need to have access to psychologists, play therapists, physiotherapists, surgeons, medics, and advocates as well in the Herbs Palsy group, and legal advice as well. So all of those things treat not just the child but the family, and I think all of that is really important to get a balanced view, to be able to move forward, to know what's happened, to be given the information to make choices, and to deliver care that's going to give the best. And you can't have one really without the other. You need all of that wrapped up. Surgery as a part cannot be done in isolation, and all the other aspects are key. You can't really have a bit without the other bits. So absolutely, I think all of it has to come together, not one part by itself.
Are there any particularly innovative treatments at the moment, Tom?
Well, in my research, and I'm sure an awful lot of my other colleagues as well, nerve injury is an area that I think is going to have a huge growth in technology very, very soon. There is no drug that we can give to make nerve injury better. Many times it's just waiting, and I'm sure, as Sean has already told us, there's this long period of time over which you see recovery. There's no ability that we have to speed that up or to change that with any medication. And there's a number of drugs which we've developed and other drugs which others have that have shown an awful lot of benefit in animal models, and we're designing human trials to bring those through now. Technologies for making the diagnosis, so looking at the nerve injury, diagnosing that with a scan. There is no scan that we can use at the minute. MRI scans don't really show the nerves. You can sometimes show if it's been pulled from the spinal cord. The injury where the nerve is avulsed can often be seen, but sometimes not. But the injury itself, to the stretching of those nerves, often cannot be seen, and we're developing techniques to do that as well. Finally, the ability now for us to have technologies to robotically improve function are growing hugely. I'm involved in a project, and we're applying for a European grant at the moment to transduce thought of movement through wireless technology, implanted stem cells, and a technique called an optogenetic control of stem cell growth into muscle. And we're hoping that we'll be able to get some funding to develop an ability to control muscles to sort of bypass the problem with the nerves. This won't come for a generation yet, but the technology is now available, and again, assistive technologies, splints, 3D printed devices. There's going to be a huge explosion. Not quite there yet, but there's an awful lot that we're working on.
Brilliant. It sounds good for the future. Got time for one final question, which Tom, you might have a view on. And it's, I have looked at cases of Erb's palsy online, and they talk about a case called Montgomery. I don't really understand. Can you help? Now, I should probably start to answer that question because Montgomery is a legal issue. It comes out of a case. And basically, Montgomery was about the fact that doctors should give enough information to a patient, including about the issues which the patient is concerned about, rather than what the doctor thinks that they should be concerned about, to allow a fully informed decision to be made. So basically what Montgomery, the decision, says is that consent is much more about the patient and their understanding, which arguably it always should have been. But Tom, you might have a view about that in practice.
Yeah, so in terms of my practice, in terms of treatment, which is applicable, in that we have the same process of informed consent and building consensus towards treatment, it has always been a difficult area to inform any patient, and particularly parents consenting for a child, as to what's in their best interest. And this obviously is applicable to the woman, to the mother giving birth as well. There are so many aspects of what could happen, and what Montgomery tells us is that we have to provide, even if there's a tiny risk, if that's going to be specifically important to the patient, then we have to discuss that. Now, there's a balance in medicine, and particularly in surgery, and surgery is pertinent here in the same way obstetrics is, because the principle of first do no harm, we can't apply. For me to cure someone as a surgeon, I have to create injury. I have to cut into that patient. It sounds horrible, but that is actually what surgery is. And so to make that step, to do something to a patient that is going to harm them, we're going to cut them to make them better, they have to understand all of those risks. And bundling those up into an easily understandable concept and weighing the benefits and the risks is really difficult for doctors and trainee doctors, never mind patients who already have an awful lot on their mind. And I think it's a concept that has to be done over a period of time. It can't be done on one day, and certainly not, as often I think is likely to happen in obstetrics, on the day of delivery, to be in that stressed environment and be asked to make complex choices. So the information has to be provided. There has to be an ability for give and take and backwards and forwards in a conversation. And it's the basic principle of caring for someone that you share the decision, so that you give as much information as you think they need. And that'll be different for every single patient, and their interaction with every single doctor will also be different. It is incredibly complicated, and I don't think it is always done well, or I know it's not always done well. I think we're getting better at it. Patients and doctors are better informed. And I think in the old days, doctors used to just go there, we'll make the choice. And those days are long gone. I think the legal system is struggling to provide a network and a framework in which we can easily test how good that consent has been. But I think it speaks to the relationship between the doctor and the patient. And it's really interesting at the end of any consultation to say, what have you as the patient taken from that? Are there any further questions? And let's come back and revisit that again before we make that the final choice. So it is complicated. I don't think Montgomery has necessarily moved us forward other than what is best practice. It medically is now stated legally that it should be specific to that patient and driven by the patient's needs.
And I think importantly, as you say, that actually it becomes a joint decision, becomes something that's done together. Absolutely, and I think that's really what the Supreme Court we're trying to get at. Unfortunately, that's all we've got time for in this online clinic, but hopefully we might run another one in the future, so please watch out for that. Thank you to Shana for all of your practical input during the clinic. Demetrius and Tom, thank you so much for giving up your valuable time when we know you are both very busy, and for all of the excellent input you have been able to give as part of the clinic. Finally, thank you to everyone who joined us online. We hope the information provided by this clinic will have been of some practical assistance, and we hope to replay the recording of this clinic in the hope that the questions and answers will help other people in respect of Erb's palsy as well. Please remember that if you need any further advice or assistance, please do not hesitate to contact us via roydswithyking.com and go to our clinical negligence pages. Thank you everyone once again.